So often questions we get about pre-gestational diabetes is what should we order on these patients? Should we order a PC ratio or 24-hour urine? And what other tests do we need? So of course we need routine prenatal labs that we get on everybody. But the one thing that we should consider is asymptomatic bacteriuria in diabetics. It's 3 to 5 times more common in diabetics than it is in non-diabetic patients. And I prefer to monitor the dipstick at each visit, and if there's nitrites and leukocytes, then consider a culture. But for sure, consider a culture at the very beginning of pregnancy, at baseline, to make sure that they do not have any asymptomatic bacteriuria. About 5% of all pregnant women have asymptomatic bacteriuria. The second thing that we need is a hemoglobin A1C. And at baseline, this gives us an idea of their risk for anomalies, and it also gives us an idea of their control for the past 2 months. When you say get a hemoglobin A1C of 10, you can look at the average glucose for the last 2 months, and the average glucose when you got a hemoglobin A1C of 10 is 240. Okay, so I had a patient look at me and say, well, I knew I shouldn't have eaten that Snickers bar before I came in here. And I said, ma'am, you know, I'm sure your blood glucose might be 240 or 250 now, but it's all the Snicker bars you have had in the last 2 months that's showing up, and just one Snicker bar will not affect your hemoglobin A1C. The next question is, how often should we repeat it? It's recommended that in pregnancy that it is repeated every 4 to 6 weeks in uncontrolled patients, or patients who are not bringing logs, or patients whose logs may not appear to be accurate, especially with their meter. And then if you have somebody who's really controlled, they are very compulsive about their blood sugars, then we should get a hemoglobin A1C at least once a trimester. The basic test that we should get on everyone is a basic metabolic panel. You might want to convert that to a complete metabolic panel where you see their liver enzymes, because obese pre-existing diabetics often have NASH, non-alcoholic hepatitis, from getting too much fat stored in their liver, and their liver enzymes are basically just a low number, 40 to 50. The other thing that you definitely want to look at on your BMP or CMP is you want to look at their creatinine. If they're to ensure their creatinine is normal. In diabetics, in type 1, 40% of patients will have a thyroid disorder, either hypo or hyperthyroidism. And for patients who are pregnant and are type 2, I order a TSH on them also. They need a dilated eye exam to look at background retinopathy if they have not had this in the last year. So the PC ratio, as you know, the guidelines from about 2012 recommended a PC ratio because it's much easier to do than a 24-hour urine, and it is also the patient is, you can get it in the office, and you don't have to have the patient bring it into your office, because a lot of times they're not non-compliant. So if a diabetic has no proteinuria, I still feel a PC ratio is okay. And if they get to be 32 weeks and you're worried about their blood pressure and stuff, then you can repeat your PC ratio. And your preeclampsia workup would be the same. But in individuals with a with baseline proteinuria, I would recommend a 24-hour urine and a creatinine clearance. And the reason being that the PC ratio doesn't correlate well with the amount of protein. And when we're trying to discriminate between, is this just increased glomerular filtration rate associated with pregnancy, or is this a preeclampsia, then we need to have a quantitative amount of proteinuria. So it's in patients who have protein that I would recommend the 24-hour baseline urine. In my mind, I always worry about who I should get an EKG on, or who I should get an echo on, okay? So baseline EKGs are important if patients have, chest pain on exertion, any kind of symptoms like more shortness of breath with walking. They should also have an EKG if they have hypertension and diabetes, and they would recommend an EKG if there's any vasculopathy, particularly retinal or renal. Now, if the EKG is abnormal, then I would recommend that they see a cardiologist and be considered for an echo and or a echo stress test. They are at much higher risk of coronary artery disease than the baseline population. Now, what are the frequency of the test? I've already talked about the hemoglobin A1C. The home glucose monitoring test, we recommend fasting and 1 hour or 2 hours after each meal. And 1 hour is expected to be lower than 140, 2 hours less than 120. Urine ketones during an illness, abdominal pain, diarrhea, nausea, and vomiting. A urine dip, a protein assessment, just a dipstick at each visit. The serum creatinine baseline and worsening proteinuria or blood pressure. The thyroid exam baseline. And again, the ophthalmological exam should be baseline and follow up with the recommendations from the ophthalmologist. If there's any suggestion of retinopathy or a potential early signs, they're going to recommend that follow-up, because retinopathy is the one thing that can be accelerated during pregnancy, especially if you're trying to get an uncontrolled diabetic back into control quickly, and it may not regress at the end of pregnancy. Then our next topics will be, oh crap.
Okay, so let me,
our next topic will be,
our next topic coming up, was this moving around on you?
yes,
Okay, 1 second, for some reason this is bouncing around.
yeah.
Okay, so coming up, our next topic on January 15th, we'll be checking blood sugars and adjusting insulin. And also, we would like to let everyone know just about other telementoring programs in South Carolina, along with our pregnancy wellness We have Project Echo Opioid Use Disorders, and there's a Southeast Viral Hepatitis Interactive Case Conference. And so if you are interested in any of those telementoring opportunities, you can go ahead and reach out to me regarding that.
And sometimes the hepatitis and the opioid disorders, they discuss pregnancy for it.